Today's class is going to take a deeper dive into cardiomyopathies. So, just to be clear, when we're talking about heart failure, we're talking about the failure of the heart to generate a proper cardiac output to meet the needs of the body. We can have acute heart failure, chronic failure, or even acute on chronic failure. When we talk about cardiomyopathies, we're going to be talking about some physical change within the heart structure. To categorize heart problems, we look at it from two basic viewpoints: problems with filling or problems with emptying. So these get termed diastolic or systolic dysfunction. Let's get started with the most common cardiomyopathy, dilated. This is going to be a systolic dysfunction or a problem with contracting and generating an effective cardiac output. We can get to a dilated ventricle by toxic effects of drugs, alcohol, or even viruses. Sometimes we don't know the cause, or it's even after a big heart attack. In all of these cases, the ventricle is filled with a large volume and stretched out, but has decreased contractility. We previously looked at preload and cardiac output on the Frank-Starling curve. We saw that as the preload increased, that we had an increase in cardiac output. However, in a dilated cardiomyopathy, we lose the contractility of the myocardium. So we still have the increased preload, but we have the loss in cardiac output that accompanies the decrease in contractility. Let's compare the two systems as a before and after. Both the end-diastolic volume and the end-systolic volume are up to maintain an adequate stroke volume, but the myocardium's loss of contractility significantly decreases the ejection fraction that we see. The exam findings here are going to be a huge heart or cardiomegaly on the x-ray and maybe an S3 heart sound. We haven't talked about that before, so let's dive into it. The S3 heart sound is a sound that is heard in early diastole when you use the bell of the stethoscope. In adults, this is usually a sign of systolic failure when the ventricle is overly compliant when it fills. If you remember, compliance is the ability to distend or accommodate extra volume, and that's what we see here in dilated or systolic dysfunction. On the other side of the coin, what if we have no problem ejecting blood, but with filling? This is called diastolic dysfunction. Here, the normal chamber volume is displaced with the excess myocardium. There usually isn't a problem with the contractility or the ejection fraction here. We may even see an increased ejection fraction. So if this patient exhibited signs of heart failure, then we would term this heart failure with preserved ejection fraction, or HFpEF. The characteristic finding in this disorder is the inability of the heart to generate an adequate preload to generate an adequate cardiac output that the body's tissue needs. So we have to think, why is the myocardium thickened? If we remember back to previous lectures, we talked about that myocardium will hypertrophy in response to an increased pressure or an increased afterload. We also have congenital defects in myocardium that leads to a thickened ventricle that can behave with diastolic dysfunction characteristics. So what are those diastolic dysfunction characteristics? Well, like we said before, diastolic dysfunction is all about the filling. So let's draw the PV loop that we're familiar with before. Diastole, or ventricular filling, happens on this bottom part, but since we have a stiffened left ventricle, we're unable to properly fill. This increases the pressure in the ventricle, but does not allow the increase in volume to happen to the same extent as before. Though we do lose some cardiac output in the form of stroke volume, the main consequence here is the significant increase in the ventricular pressure. When you put the two curves side to side, you can see the difference in the two systems. Both cases, we see an increased left ventricular end diastolic pressure. The pressure came in two different forms though. One, pure volume, and the other, the lack of space to fill with volume. There is another form of cardiomyopathy known as restrictive or infiltrative cardiomyopathy. Here, there is deposition or disturbance of the myocardial tissues themselves, preventing proper relaxation. This gives us a form of diastolic dysfunction. This can occur in the case of amyloidosis or after chemo or radiation treatment. We won't discuss this any further, and you may not even discuss it in class, but do remember to go back to the underlying pathologic mechanism that has occurred within the heart to give us the certain type of cardiomyopathy. You'll have to remember how the body has compensated for the fall in cardiac output when you think about the type of treatment that your patient may need if they presented with signs and symptoms of heart failure. This will be one of the more difficult lectures that you will have during your physiology course, but try and talk through the situations and scenarios with your friends and see if you can't figure out the underlying pathologic and physiologic mechanisms at play. Good luck with your studies, and thank you for watching.